So this is just technique for adult lateral hip, and obviously when you roll them like this, the bursa is going to displace front and back. So if we want to look for bursitis, it's good to do that straight away. You can do it laying flat as well, but I'll just show you a side-on technique. So this is called the plonk and run. So we basically plonk down here on the femur, and you can see a nice juicy vastus lateralis muscle from here to here. And then you just run up until that muscle disappears, so it gets thinner and thinner at the top. You're sort of aiming to milk the bursal fluid up, so you're sort of putting lots of pressure, and then when we arrive at the greater trochanter, you can see the vastus lateralis has disappeared. You take your pressure off, and then we can just see from here to here, this is the ITB, so the iliotibial band. And the bursa, sometimes you'll see it distended there, but if we go a little higher, you can see there's two different facets on the bone. So the one towards the front is called the anterior facet, and that's where gluteus minimus inserts. The one back here is lateral facet. So let's do the plonk and run again. So we're coming up, our bone's going to have a little point, so we put the point facing up. You're at the point where it's shallowest, closest to the skin. And now we can see a muscle emerging on the front. This is the tensor fasciae latae. And we don't want to see that muscle smack down against the bone. You want a bit of volume in between. So we want to see something lifting that TFL up. And what we've got is the gluteus minimus. So if you're too low, it'll look like there's no glute min. You can just see TFL. So one of the things is obviously you've got to be high enough to see minimus. And then notice how when you're on this point here, the minimus margin slopes anteriorly. So it's basically coming from over there near the wall, so facing the wall. So if I was to turn into long to get that tendon, I can't be smack bang on top of the tendon with a vertical probe angle. I've got to come in from that anterior approach to try and get the tendon fibres to reflect. So one of the things we do is look at the ASIS of the patient, and you draw a line imaginary from point of the hip to the ASIS, put your probe on there. But then what I would do is go too far forward, lean your camera, lay it back towards the wall, so you're taking an anterior approach, and then just sweep backwards. So by sweeping backwards, you'll fall onto that gluteus minimus. So you can see it's a very oblique angle. In a bad picture, it sort of looks like that. So it's diving away from you. So we want to bring the bursal surface up parallel with the probe. So we push the top of the camera in. By flattening it out, now it's reflecting nicely. So you've gotten rid of that anisotropy. So if you're on minimus, you should see a triangular TFL muscle over the top. To look for the bursa, you run your eye from the bone up to the very first white line, and the bursa is anything immediately on top of that. So it's actually very thin and normal here. So you run your eye from bone up to the first white line, that little black stripe, that's bursa in there. Okay, so that's minimus. So you can also image it in transverse like this. So we just take one image zoomed, and we just call that transverse minimus anterior facet. Notice how normally it thins out or becomes triangular towards this point here. So that's very normal, it's not a tear. So then we have what we call an interval where there's no tendon. So between minimus and medius, there's no tendon just here. So if we were to turn longitudinally on that point, it looks like there's no tendon at all, and that's a normal finding. So that we'll look for medius now. So if you plonk and run up until you see that pointy bit again. Now when you can see minimus in trans, you won't be able to see medius in trans yet. So the first thing to do is to rock onto the posterior aspect of your probe. So you're heeling in toe until that is a little bit more parallel with the top of the screen. Then you go further north, so slide proximally, and then angle back down, just a slight tilt from a superior approach. And then the aim is to try and make your medius tendon look the same volume from front to back. So it's going to look like a supraspinatus in the shoulder. So here I am where you can't see it, I'm moving up and angling back down. And the medius is naturally just a very, very thin tendon, so all we're getting here is from the bone up to the first white line. That's medius from front to back, and it's quite broad, so it's going from here all the way back to here. So if I was to measure the thickness, I could measure it like that. Then obviously we want to image it in longitudinal, in anterior, mid and post. So if you turn into long, it's very easy to get lost. So what you can do is one of two things. You can either slide back off the greater trochanter until you've completely fallen off the trochanter and there's no bone, and then just slowly slide forward until you see the first glimpse of tendon. So this would be the posterior medius, and we call it the lateral facet because there's two tendons we're going to be looking at. So from here we slide forward, we stand the camera up a little taller. This is now the mid medius, and this is the anterior aspect, and now we're seeing no tendon, so we're back on the interval between medius and minimus. So if I now oblique the probe, point back at the ASIS, I'm back onto minimus. So the second technique to find medius lateral facet is to transition from your minimus back onto the lateral facet medius. So all you would do is rotate back into the true long axis of the femur, and then just slide past the interval where there's no tendon. And then the first tendon we see is medius lateral facet, and I find it's helpful if you just tilt the camera back a little bit. So sometimes if you slide back and angle forward, it just brightens that tendon up. So this is now glute max, so we can slide back through that lateral facet just to survey the whole tendon. And then finally, when you see the bone take a steep dive, so see where you see the change of the bone angle there, we've just transitioned onto the second medius tendon. So you'll need a lot of probe pressure and a lower frequency. Focal zone has to move down, and the approach of the camera, instead of being quite vertical, is now like you're scooping in from behind, a posterior approach. And it should look like quite a large Achilles, so it's a lot thicker than the lateral facet, and the bone is a steeper shape. So that's the posterosuperior facet of medius. So that's just in a nutshell there, the gluteal tendons and the imaging series. But to finish, I'd normally always look at the ITB from its point of origin on the iliac crest. So at that point you sort of need a little bit higher like that. You start at the ASIS, and our probe's just in a true longitudinal. We set it very shallow, so we would move our focal zone and depth right up like this. And you're just going to slide along that origin, just looking for enthesopathy, any thickening of that ITB origin. So all we're looking at is this tiny little tendon here. So that's the ITB origin, whereas this is the tensor fasciae latae muscle. And sometimes we see changes up here in people with lateral hip pain. So you just run back looking at the thickness of that on the iliac crest. And finally, if we stay quite anterior near the ASIS, in this line you're going to see the minimus muscle belly. So from the ITB down to that white fascia there, that's all TFL, and this is the minimus that flanks the joint. So you get this lovely view of the minimus. You can check it's not atrophied, which would be the case in a chronic full thickness tear, and we can see the musculotendinous junction of the minimus coming back down onto the minimus tendon, and finally the anterior facet. So there's nice, normal, healthy minimus. You can try and learn to trigger it if you're trying to assess whether there has been a rupture. What we're going to do is get you to imagine dragging your knee, or drawing the knee, anteriorly up towards your belly. Yep. But then switch everything off, so just relax it all for the moment. So what we're going to do is more like a pretend to engage the muscle but don't actually move. So if I was to touch your kneecap, you're going to just push against my fingers by 1 millimetre or 2. So I'll get you to relax everything, switch it all off. So you can see there's a slight sort of sag in this area here between the muscle belly and the tendon. And now if I get you to think about drawing your knee towards your belly but don't actually move yet, and then just go to engage as if you're going to move the kneecap forward. And now just push against my fingers, tiny little movement. So just relax, so don't clamshell at all, so it's not lifting up, it's just going forward. So tiny little movement again. There you go, and switch it off. Tiny little movement again, and switch it off. So you'll find that helpful when it pulls tight. You can see that it's intact, it's not sagging anymore, so you know the minimus is there. Alright, so a couple little pitfalls just to finish. Is striated, it sort of goes white, black, white, black, white. So all these are normal, they're not bursas. The reason being is the top layer of the hip is made up of TFL muscle fibres and the gluteus maximus muscle fibres that all sort of insert into the ITB. So they're just all little slips of muscle within that ITB. So if you're looking for a bursa, the only way to do it safely is to run your eye from the bone up to the first white line, and then from here up to the undersurface of the maximus fascia, that's the bursa. So over minimus in trans, you'd be running your eye from the anterior facet up to the bursal surface, and then the bursa would be sitting here beneath the TFL or beneath the ITB. So you can sort of lawn mow just to double check. So by lawn mowing I mean start superiorly, run down in stripes like that, and you've covered all of the bursa or all regions where fluid could exist.